Hello, welcome to the monthly teaching video of Safe Space Community. SSC 6 to equip the body of Christ with basic mental health literacy from the medical, psychological, spiritual, and relational perspectives by integrating psychology and theology. This is session number 16. I am Dr. Edmund, a licensed psychotherapist, and I am your facilitator in SSC. The title of today's topic is Trauma: Understand, Identify, and Address. You will learn, first of all, what is the nature of trauma. Then I will tell you more about the neurobiology of trauma. Then how do you identify trauma? And then I'll proceed to addressing trauma and self-care. And finally, I will talk about the spiritual approach to trauma. So the nature of trauma. What is trauma? Trauma is the difficulty to cope with one or a series of stressful events or circumstances that are experienced as deeply distressing, disturbing, or less than nurturing, often leaving a lasting negative impact on the person's mental, emotional, and sometimes physical well-being. So what are the types of trauma? Trauma can be categorized into various types based on its origin, duration, and impact. The categories are not mutually exclusive, and the common ones include the following. First of all, we have acute trauma. This results from a single isolated event such as a car accident, natural disaster, or physical assault. Acute trauma typically has a clear onset and may lead to immediate distress and symptoms. Then there is chronic trauma. This involves repeated exposure to distressing events over an extended period. Examples include ongoing physical or emotional abuse, living in a war zone, or experiencing long-term neglect. Chronic trauma can have cumulative effects and may result in complex psychological and emotional difficulties. Third, we have vicarious trauma. Vicarious or secondary trauma occurs when individuals are indirectly exposed to traumatic events through their work or relationships with others who may have experienced the trauma. This can include healthcare professionals, first responders, therapists, and individuals supporting loved ones who have been traumatized. Secondary trauma can lead to symptoms similar to those experienced by direct trauma survivors, including emotional distress, burnout, and compassion fatigue. Then there is interpersonal trauma. This involves traumatic experiences that occur within the context of relationships or social interactions. This can include physical or sexual abuse, domestic violence, bullying, or betrayal by a trusted individual. Interpersonal trauma can have profound effects on an individual's sense of trust, safety, and self-worth, often impacting their ability to form healthy relationships in the future. And two more. The first is developmental trauma. This occurs during critical periods of a person's development, particularly in childhood, and can have lasting effects on the psychological, emotional, and social functioning. This type of trauma can result from experiences such as neglect, abandonment, or attachment disruptions during infancy and childhood, leading to challenges in emotional regulation, self-concept, and interpersonal relationships later in life. And finally, complex trauma, also known as complex post-traumatic stress disorder. This type of trauma typically arises from prolonged and repetitive exposure to traumatic events, often during childhood, or within the context of interpersonal relationships. Complex trauma can result from experiences such as childhood abuse, neglect, or growing up in a dysfunctional family environment. It can lead to a wide range of symptoms, including difficulties with emotional regulation, self-esteem, and forming healthy relationships. And so, continuing with the nature of trauma, what are the reactions and symptoms? The reactions and symptoms of trauma can vary widely depending on the individual, the type of trauma experience, resilience, coping mechanisms, and available support systems. However, there are some common symptoms which may manifest in different ways. First of all, we have intrusive cognition, recurrent and distressing thoughts, memories, or flashbacks of the traumatic event. These intrusions can be triggered by reminders or cues related to the trauma. Then there is emotional dysregulation, difficulty regulating emotions, leading to mood swings, emotional numbness, or emotional outbursts. This may include feeling overwhelmed by emotions or feeling emotionally detached from oneself or others. Then another common reaction and symptom is reactivity to triggers. Strong emotional and physiological reactions to reminders or cues associated with the traumatic events, such as sudden noises, specific smells, or situations reminiscent of the trauma. Then there is avoidance behaviors. Efforts to avoid reminders of the traumatic event, including avoiding certain places, people, activities, or conversations that may trigger distressing memories or emotions. There is also hyperarousal, heightened states of arousal or vigilance, leading to symptoms such as irritability, anger, difficulty concentrating, hypervigilance, exaggerated startle response, and difficulty in sleeping. Then there are also physical symptoms. Trauma can manifest in physical symptoms such as headaches, gastrointestinal problems, muscle tension, fatigue, and other stress-related ailments. There is also negative mood and cognition. Persistent negative emotional states such as fear, horror, anger, guilt, or shame, feelings of detachment or estrangement from others, difficulty experiencing positive emotions, persistent negative beliefs or expectations about oneself, others, or the world, and distorted blame or guilt related to the traumatic event. Then there are interpersonal difficulties, difficulty forming or maintaining relationships, social withdrawal, distrust of others, feelings of isolation or alienation, or challenges with intimacy and communication. Then there's distorted thinking, distorted thoughts or beliefs about oneself, others, or the world, such as feeling permanently damaged or worthless, or having a sense of foreshortened future. And finally, there are changes in self-identity. Trauma can lead to shifts in self-perception, identity, and worldview. Individuals may struggle with questions about their identity, purpose, or beliefs about the world and their place in it. Now, let me talk about the neurobiology of trauma. The neurobiology of trauma encompasses the complex physiological and psychological responses that occur in the brain following a traumatic event. Understanding the neurobiology of trauma is essential for developing trauma-informed interventions and therapies that address both the physiological and psychological aspects of trauma recovery. The parts of the brain are often illustrated with the hand, with the fingers representing the prefrontal cortex and the thumb representing the amygdala. So somewhere in the middle of the palm is the thalamus and the pituitary glands. The prefrontal cortex is responsible for executive functions such as decision-making, impulse control, and emotional regulation. The amygdala is that part of the brain involved in processing emotions, particularly fear and threat detection, much like the smoke detector to protect us. Data from our 5 senses is sent to the thalamus, acting like a relay station for distribution to the prefrontal cortex and the amygdala. When the data appears traumatic and threatening to the person, the amygdala becomes hyperactive and triggers off the body's stress response system to fight, flee, or freeze. The pituitary glands, which regulate the body stress response, now becomes dysregulated, leading to excessive production of stress hormones such as cortisol to arouse hypervigilance, irritability, and emotional dysregulation. At the same time, the amygdala blocks the slow-thinking prefrontal cortex, leading to difficulties in cognition processing, memory consolidation, and emotional regulation, thus contributing to symptoms such as intrusive memories, flashbacks, and avoidance behaviors. As the amygdala is involved in encoding the emotional significance of our experiences, traumatic events can result in particularly strong and vivid memories that perpetuate heightened emotional reactivity and sensitivity to potential threats through neuroplasticity to persist long after the actual event, thus leading to reactions and symptoms of trauma, much like an oversensitive smoke detector that keeps getting triggered unnecessarily. So we now come to identifying trauma. First, we have the clinical interview. The first step in diagnosing trauma involves a thorough clinical interview conducted by a mental health provider. During this interview, the clinician will gather information about the individual's personal history, including any traumatic experiences that they may have had, as well as their current symptoms, coping mechanisms, and functioning in various areas of life. Then there is assessment of the traumatic exposure. The clinician will assess the individual's history of exposure to potentially traumatic events such as accidents, abuse, violence, natural disasters, or other distressing experiences. This may involve asking specific questions about past traumas and their impact on the individual's life. Then comes the assessment of symptoms. The symptoms commonly assessed include intrusive thoughts or memories, avoidance behaviors, hyperarousal, negative changes in mood and cognition, and changes in emotional regulation. The clinician will then evaluate the individual's current symptoms to determine whether they meet the criteria for certain trauma-related disorders. And now I will go through 2 common trauma-related disorders. First, the post-traumatic stress disorder, or PTSD. Now, this is for persons above 6 years old. First of all, there has to be exposure to actual or threatened death, serious injury, or sexual violence, either by direct experience, witnessing the event, learning about it, or workplace in-person exposure to aversive details for people such as first responders or police officers. And the symptoms include distressing memories, recurrent dreams, flashbacks, or dissociative reactions distress to triggers or cues. Then there is avoidance of memories, thoughts or feelings of the trauma, external reminders such as people, places, activities, or situations. Another criteria is that there is negative alterations in cognitive or mood, such as inability to remember the trauma, exaggerated beliefs or expectations, example, no one can trust me, self-blame, fear, horror, anger, guilt, or shame. The fifth criteria is arousal and reactivity, such as irritable behavior, recklessness, self-destruction, hypervigilance, startle response, sleep disturbance, and problem with concentration. Now, the sixth criteria is important. Duration of the disturbances, that is items 2 to 5, is more than 1 month, and the disturbances cause significant impairment in social, occupational, or other important areas of functioning. Now, note that if the symptoms appear 3 days to 1 month after the traumatic exposure, that is not more than 1 month, then the disturbance is called acute stress disorder and not PTSD. Now, let us talk about PTSD for children 6 years and younger. The exposure is the same, but the symptoms here includes distressing memories, recurrent dreams, flashbacks, dissociated actions, distress to triggers or cues. They sometimes can be expressed as play enactment. And another distinction is that the negative alterations in cognition or mood includes diminished interest in play activities, socially withdrawn behavior, and reduction in positive emotions. And also the same thing here, duration of the disturbances is more than 1 month. And a final distinction, the disturbances causes significant impairment in relationships with parents, siblings, peers, or caregivers. Next, in identifying trauma is the use of standardized measures. Mental health providers may use standardized assessment tools, questionnaires, or rating scales to measure the severity of trauma-related symptoms and track changes over time. These measures can help provide objective data and guide treatment planning. The gold standard for diagnosing PTSD is a structured clinical interview, such as the clinician-administered PTSD scale, or CAPS-5. But for general use, the PTSD checklist for DSM-5 can provide a provisional diagnosis. The PCL-5 is a 20-item self-report measure. The score of 31 to 33 is indicative of probable PTSD, and a 5 to 10 point change represents a reliable change, and a 10 to 20 point change represents a clinically significant change. Now, the PTSD checklist is shown here. The respondent will tick for each of the questions whether it's 0 to 4. 0 representing not at all, and 4 is the extreme case. Next, we come to addressing trauma. The goal of addressing trauma is to help individuals process and integrate their experiences, reduce symptoms, improve coping skills, and enhance overall well-being. The following are some common psychological approaches to address trauma. First of all, we have the trauma-focused cognitive behavioral therapy. This technique helps individuals to recognize and reframe distorted beliefs about themselves, others, and the world, thus reducing symptoms such as anxiety, depression, and avoidance behaviors. Then there is the mindfulness therapy. This technique can help individuals develop greater awareness of their thoughts, emotions, and bodily sensations. Mindfulness practices can promote relaxation, emotional regulations, and acceptance of difficult experiences, which can be particularly beneficial for trauma survivors. And then there is the exposure therapy. This involves gradual and systematic exposure to trauma-related memories, reminders, or situations in a safe and controlled manner. Exposure therapy aims to reduce avoidance behaviors and desensitize individuals to traumatic triggers, ultimately decreasing the intensity of traumatic reactions. And finally, there is the psychodynamic therapy. Through self-exploration and the therapeutic relationship, individuals can gain insight into their experiences, develop self-awareness, and process unresolved feelings associated with the trauma. There may be times when medication is necessary. Antidepressants, self-anxiety medications, and other psychotropic medications may be used as part of a comprehensive treatment plan, particularly when symptoms are severe or significantly impairing functioning. Here, I would like to put forward a psycho-spiritual approach. First of all, the neurobiological aspects. The trauma is stored in our memories. Memories are formed by the reactivation of a specific group of nerve cells called neurons through the persistent changes in the strength of connections between them. The persistent change in the strength of the connection is termed synaptic plasticity. Neurons that fire together wire together. The trauma memories can be restructured through the creation of healthy reparative memories as alternative routes for the synapses to travel on when the trauma is triggered. The good news is that we can create the healthy alternative routes without reliving those events in real life. Neuroscience researchers has found that mental imagery can change our multisensory perceptions. In other words, our imagination can create reality at the neuronal level. To be effective, the technique to address trauma through imagery has to be experienced as real as possible. The experiencing is key for effectiveness. Now, the process. Step 1, focus on the symptomatic intervention of the presenting problems to relieve the suffering. Step 2, resurface the trauma from its hiddenness by helping the client to be more aware of how they react in the face of the trauma triggers. Step 3, get the client to relax, close the eyes, and imagine walking into his past memories. Step 4, select one original traumatic incident. This is called the governing scene. Step 5, re-experience the governing scene as real as possible and verbalize the consequence and emotions embedded in the memory. Step 6, ask the client to invite Jesus to come into the governing scene to rescue the person from the traumatic incident and then give him or her some reassuring words. Then emerge from the imagery, open your eyes, and deep breath. The purpose is to repair the trauma of the original experience, to create through imagery a favorable memory out of the past traumatic scene as an alternative route for the memory synapses to travel. Now let me talk about self-care. Here are some self-care recommendations. First, acknowledge the trauma. Take some time to reflect on your thoughts and emotions and try to identify any patterns or recurring themes. Next, sit down and write down your experiences and emotions and try to connect them to any past life experiences that may have caused them. Seek social support. A strong network of supporting loved ones and friends can provide you with a nurturing environment that will help you rebuild trust in others while getting emotional support. Then ventilate your emotions. Voice out how you're feeling to people who understand what you're going through. Repressing your negative emotions can worsen your condition. Exercise. Regular physical activity is crucial for good physical and mental health. Exercise can relieve stress and boost your mood. Then develop coping strategies against triggers. This include, first of all, grounding techniques, breathing exercises, relaxation techniques, the 5-5-5 rule for grounding, and other medical, physiological, psychological, spiritual, and relational coping strategies are given in our SSC teaching video V16 entitled Managing Anxiety and Panic Attacks. Another coping strategy is distraction. Engaging in activities or hobbies that provide a sense of enjoyment and relaxation can be a form of distraction from triggers. Then there's self-talk. Practicing positive self-talk can help people reframe negative thoughts and emotions. And two more self-care recommendations. Pursue post-traumatic growth. Despite the profound pain you endure, you have the potential to discover newfound strength and resilience. Through self-reflection and healing, you may gain a deeper understanding of yourself, your values, and your priorities. And finally, be patient with yourself. Be patient with yourself, show yourself kindness, and celebrate every small win. Every little bit of progress can bring you closer to healing from trauma, reclaiming your strength, and finding your way to a brighter future. Now, finally, I like to talk about spiritual approaches to trauma. Spiritual approaches to trauma are not recommended as the sole remedy, but as a complement to therapeutic interventions and self-care. Integrating spiritual resources and practices into the healing process can provide individuals with additional resources of support, meaning, and resilience on their journey toward recovery. First of all, spiritual support. Engaging with church leaders and Christian counselors can provide valuable listening ears, prayer, guidance, and encouragement, and other forms of spiritual support. Then there is prayer and meditation. Prayer and meditation are powerful means to connect with God and find inner peace, comfort, strength, and clarity during times of distress. And to engage in meditation, one best way is to refer to our SSC video V10 entitled Guided Christian Meditation Session for Mental Health and Intimacy with God. Then there is Lectio Divina. This is a 5th century Benedictine approach to prayer, to let God speak through Scripture. Lectio Divina ought to be practiced for 30 minutes or more daily at any time of the day. First, we choose a short passage of Scripture, then settle down into a prayerful posture and breathe slowly to quieten yourself. Then read the chosen passage slowly 3 times, aloud if desired, and chew on it as if eating a good meal. Pay attention to a word or phrase that speaks most to you. Allow the word or phrase to be absorbed into every sphere of your life and examine what God is saying to you through it. Then pray what God is leading you to pray in response to the word or phrase. And finally, wait patiently on God for 10 to 15 minutes and sense what God is revealing to you, and end your time with a prayer of thanks. Some Bible verses that you can focus on for trauma in Lectio Divina are as follows. Psalms 34:18, Psalm 46:1, John 14:27, Romans 2:28, Philippians 4:6-7. And finally, 2 more spiritual approaches to trauma. First, practicing forgiveness. Releasing and receiving forgiveness can release the burden of resentment, anger, and bitterness, allowing the individuals to experience greater freedom and healing from past traumas. And finally, community. Being part of a Christian support group for trauma survivors, or even a cell group with people who can empathize with your pain, can provide a sense of solidarity and belonging, helping individuals feel less isolated and alone in their struggles. This comes to the end of this month's teaching video. I wish to thank you for watching our SSC series. This is session number 16, and the topic is trauma. Understand, identify, and address. To receive our latest free monthly video teachings and case study blogs, kindly subscribe to our website at www.safespacecom.org. I look forward to seeing you again. Bye for now.